there's been a debate for a long time between the morphine versus the fentanyl thing for the treatment.
Yes.
This kind of stuff. With a side effect being respiratory depression of the morphine and potentially having to give multiple doses, what's your take on which one may be potentially better for the patient?
I will tell you that a lot of systems are navigating towards fentanyl because of that reason. Although when you look at the ACS guidelines, they still talk about morphine being more beneficial. Actually, it's a toss-up. You know, a lot of physicians are now moving towards fentanyl because it's easier to use and better to use for patients. So I guess I don't have, personally, I don't have a preference one way or the other. I've always used morphine. I'm used to using morphine. But again, with the blood pressure effects that come with it and some other concerns, I can certainly see why you will away from it. So it is what it is. Any other questions? All right, let's jump into Module 4. We're on the downhill slide now. So we want to stay in the vein of discussion of the acute coronary syndromes, but this module centers more upon identifying those patients that are in need of acute reperfusion therapy. So for my EMS partners here, when we think about encountering these patients in the field, do we weigh towards one hospital versus the other? Or even in hospital systems, if you're in a very rural setting, do you have in-house capabilities that can handle that patient, or does the patient need to be transferred out? So of course, what we're talking about here are two very definitive therapies. The first one is thrombolysis. Now I can tell you that thrombolytics have gone to the wayside throughout the last number of years. These used to be big in the mid-'80s. Every hospital could stock them. Patients could go in, they could have the drug administered, and they had to weigh the risk-benefit for the patient. You know, not everybody could receive a thrombolytic. It's a very caustic drug, and there were rule-outs. Certain patients couldn't receive these drugs because of the caustic side effects. The other option, of course, is taking your patient to a cath lab, where they actually go in, put a white guide wire in, catheter goes in, they visualize on a screen, they find where the blockage is, and then they can go ahead and actually extract the clot, dissolve the clot, put in a stent, and have better blood flow. So those are the two options. I will tell you that thrombolytics are very rarely used anymore, specifically in this area. They tend to be used more on those facilities where there's a long distance to get to a more tertiary center where they can offer cath lab facilities. So there are options out there. And of course, what we're talking about here is finding the culprit artery and rendering care, much like you see here. We have a total LAD occlusion. You can see this vessel is completely gone because there's almost a total occlusion. And then after deployment of a stent, we see a rapid flow into that area. And these are eye-opening experiences, and many of you have been involved with these if you've done cath lab experience. So the key to reperfusion therapy is the 12-lead. Remember I said at the beginning, while we're taught to treat the patient, not the monitor, it's not necessarily true in ACS care. That information that lies on the monitor helps direct what we need to do with the patient. And you can't see ST segment deviation without a 12-lead EKG. So we ask of you to do these very early with your patients, usually within 5 to 10 minutes once you get on scene, or you encounter a patient, and you repeat them frequently. You know, every 5 to 10 minutes, or at least with a change in patient symptoms. And we trend that EKG over time. So back in August of 2003, there was a very profound article that was published in the New England Journal of Medicine to try to answer the age-old debate, which is better, thrombolysis or cath lab? And I'll just give you a conclusionary statement. Basically, it says this: if you live within an area where you can be triaged to a cath center in under 30 minutes, that's the best treatment for you. So that being said, I'll talk about our system, Lucas County EMS, and many of the other outlying systems have fallen suit. Because we're able to do that, in January of 2004, we started a diversionary protocol that any STEMI patient picked up in the field would go to a specialized center. And currently in Lucas County, there are 5 of them. So we will divert STEMI patients specifically to those centers, and that's why, again, thrombolytics have somewhat fallen out of favor. Okay, so that's our approach now. So there are 3 subsets that your 12-lead can go into. We've already talked about what's suspicious for ischemia and injury, but what do we do with the EKG that looks normal? There's no abnormality to it at all, but yet we've got a symptomatic patient. How do we handle that scenario? So we're going to talk through some of those. So let's talk about the non-diagnostic EKG. This is terminology I hear almost on a daily basis from paramedics from the field. Yeah, we've got this patient, here are the symptoms, here are the vital signs, and their 12-lead is non-diagnostic. What are they essentially telling us? EKG looks normal, right? And I told you at the top of this, there's a good number of patients that will not transition their EKG in the first several hours. So what do we do with the patient that's having chest pain, difficulty breathing, feel like an elephant sitting on their chest? We do a 12-lead, we keep repeating the 12-lead, and the 12-lead is normal. We treat their symptoms, we try to minimize their symptoms, but does it really matter where that patient goes? That's the question. If I had the choice of a STEMI center here versus a hospital that doesn't offer cath services, does it matter where I go? Where should I go? So I heard up here the STEMI center. Any other thoughts? So what if we started taking every patient with chest pain with normal EKGs to a STEMI center? What's going to happen? We're going to overload them, aren't we? So let's think about that process. Think about it right now. Think about some of the patients that you've transported over time. EKG is non-diagnostic. You dump them off into the ER. How does the ER handle those patients? They will check blood values, check for cardiac enzyme markers. They'll repeat the 12-lead. Do they rush them to the cath lab? They do not. They will do the same thing. They'll try to minimize symptoms, keep watching the EKG for a change, and if the EKG never changes and they're able to solve their symptoms, then what do they do with them? Discharge them, follow up with the cardiologist, or they may hold them and say, hey, we're going to stress test you tomorrow. Or we're going to stress test you on Monday because now it's Friday. So I guess what I'm trying to drive home here is it's not an emergent setting. So one of the things we get in our heads as paramedics is, well, symptomatic patient, I'm just going to send them to a STEMI center because now I don't have to worry about anything. The problem is we're going to inundate those facilities with all these patients that don't need to be there. So our approach currently is, if there's not something showing on the EKG, we will take them to the closest facility. Okay? And I'm not telling you guys what to do. I'm not telling you how to change your protocols. I'm just saying that's the way that we're approaching that in the county. Okay? Sorry. So the EKG we're talking about is something similar to this. If you guys look at page 4, scroll your eyes through that for just a moment. And everything looks pretty normal, right? No SD deviations, no T-wave changes, nothing that we need to be alarmed about. Now let's talk about the EKG that's suspicious for ischemia. J-point, ST segment depression, T-wave inversion. We have a concern for this patient that they may be in the process of infarcting. The question is, are they a candidate for reperfusion therapy? And the answer is yes, with some hesitation. Meaning, if you can get to a cath center in under 30 minutes, it makes sense. Although, if thrombolytics are the only option, they will not give thrombolytics to an ischemic EKG. You know why? It kills it. It's the injury that's the concern, not the ischemic change. So in our protocol, while it's not well defined, even though it's not stamped as a STEMI at the top, if I have a forward-thinking medic in the field, puts a symptomatic patient together with a globally ischemic EKG, the light bulb should go off. This patient's in the process, I'm going to treat them accordingly, and I am going to triage them to a STEMI center. Because more often than not, they will require an emergent cath. So there's a thought process that has to go into this. And then what about, look at this EKG on page 5. We've actually already looked at this EKG once today. You remember it? Globally ischemic, flat ST segments. There's that fancy term I showed you before, subendocardial injury. This is the patient I'm talking about. There are significant change here that should concern us. Now let's talk about the EKG that's suspicious for injury, the one that we've been looking at all morning long. True injured myocardial cells. Options for those patients, thrombolytics or PTCA. But again, given that time that we can get them to the hospital, PTCA is the gold standard here. And since we started diverting patients in January 2004, we've seen some phenomenal cath times. And EMS providers, nurses that work in the ED, you guys play a vital role in that. Early notification, early identification, which helps speed the time to treatment. So the key here again is the 12-lead EKG and the transition. We put that together with our patient's symptoms. And then it helps better define the treatment plan for our patient. So if you look at the EKG on page 6, just give that a look for a second here. I think you would all agree with me that this would fit into the injury subset, correct? Where's the injury at? Good, inferior, as well as you've got some lateral involvement. This is the one that we know in our head, especially after seeing it stamped at the top. This patient's in the process of infarcting. It's time to think about where we need to go. And the STEMI center or cath center is optimal for this patient. So as we prep our patients, I remember the time of thrombolytics. Most of you don't. There was a time that we used, as medics, used to carry thrombolytic check sheets. Remember those, Barb? Tim probably remembers those. Before we started diverting patients, we would take them to the closest facility because every hospital could use a thrombolytic. But yet, like I mentioned, there are rule-outs to that clot-busting drug. There are caustic side effects. So we would actually triage them in the field. We'd fill out a sheet, and then based upon the outcome of that evaluation, we knew in our head whether that patient could receive that medication or not. And then we would then prep our patients by getting additional lines. And if this patient was high propensity for sudden cardiac arrest, we would have defib pads already attached to their chest. If you're not familiar with those old check sheets, these were some of the questions that were asked. Any recent bleeding, you're a rule out. Any trauma, rule out. Sometimes if you're advanced age, above 75 years old, you are a rule out. Any recent trauma, somebody thumping on your chest, previous cardiac arrest, you would be a rule out. So not every patient could receive that medication. Again, we work towards starting multiple lines. It helps out the hospital after the transition of care. Now, I remember years ago, and I'm sure some of the others do, we used to draw blood in the field. We used to draw green top tubes, sometimes purple, we had a whole gamut. Most systems aren't doing that anymore, because why? They'd throw them out as soon as you got there. The collection process couldn't be maintained, and many times it wasn't used, so we just kind of got away from it. I hear, and I don't know if this is true, that that's making a comeback, that we're going to start drawing blood in the field again. That we're going to kind of refine that process and start looking at some of these markers early on. Whether that actually happens, I don't know. But certainly in a hospital, that's what they'll do. Check enzyme levels, recheck those, and look for a development over time. Defibrillectrodes. I am of the mindset, and again, I'm not telling you to change what you do, but just consider this. If I have an ACS patient that I've confirmed in my head in the field that that's what I have, regardless of whether they're in arrest or not, the defib pads are attached to their chest. That way, if they do arrest on me, it's a time savings. And I can rapidly defibrillate that patient with no gap in time. So we prep, always thinking about what's going to happen next. And if I have to pace my patient, my pads are already in place also. And then, of course, we try and select the correct destination. And like I said, in Lucas County, we've got 5 sites that patients can go to. Most of you are familiar with those. So again, depending on where you ultimately end up landing and where you end up working, it's nice to know what your area has to offer patients when it comes to definitive care. So let's look at a couple of cases here. We're on page 8. Take a look at the patient presentation. 71-year-old, weakness, vital signs are listed for you. Without going any further, what do you guys think of that story? Kind of blah, huh? Weakness. Only risk factors that you evaluate are advanced age, nothing else going on. You acquired her 12 lead, it's on page 9. For just having weakness, she's got a very dramatic looking EKG. Would you all agree? And what would you diagnose this as? She's got an extensive anterior stem. Septal anterior lateral leads. Reciprocal change in the inferior leads. Atypical presentation. So as we mount a response for her and what we're going to do, actually we have to think about oxygenation status. Would aspirin be beneficial to her? Yes. Nitro? Yes. Morphine? Depending on what her anxiety level is, but she's not having any pain. But definitely, she would benefit from relieving vasospasm and definitely for antiplatelet therapy. And then when it comes to deciding where she needs to go, I think you would all agree that a cath center is most appropriate for her because she's got an injury pattern showing on her EKG. How about the second case? 54-year-old sudden onset, dull chest pain, 4 out of 10. Recent, dizziness, vital signs. Take a look at the third bullet up here. Are these important? The fact that she had a previous hysterectomy and peptic ulcer disease. Why is the hysterectomy important? Yes?
I would think the peptic ulcer because it could be giving her problems and causing pain.
Okay,
I'm assuming it has to do with hormones.
Good.
Therapy.
so when a woman has a hysterectomy, total hysterectomy, she loses release of estrogen in her body. Many patients are on estrogen replacement therapy. And if you did not know this, estrogen, a hormone, is cardioprotective. That's why the incidence of coronary vascular disease is lower in a woman than it is in a man. But once they lose that hormone release, if they are not taking hormone replacement therapy, guess what? Their incidence of coronary vascular disease skyrockets just as much as a man. So that is a risk factor to her, just by given the fact that she's had that operation. Now, peptic ulcer comes in. If we were in a thrombolytic age, this might be a concern for me. Because if this patient had past bleeding in the stomach, I would not want to give a drug that's going to cause bleeding. So we're going to keep that in the back of our head and be considering that. We look at her vital signs, really not too bad, and then we find some other things. She smokes 2 packs a day, extensive family history, so as we start piling the risk factors on, your index for suspicion on that patient is much greater. Then we take a look at her 12-week. So why don't you guys take a gander at that and tell me what you think. Thoughts? I will uncover the algorithm for you to see if it offers anything to you. It does not. So you're on your own. So of the choices you have, of the subset that you're going to throw this into, non-diagnostic, ischemic, or injury, which one would this fall into? Non-diagnostic. Everybody agree with that? Nothing really major going on. So now we've got this EKG, but then we have to go back to her symptoms. Does that not paint a picture of ACS to you? So the question is, how do we approach care for this patient? Is it different from the previous one that we just looked at? Would we use aspirin? Sure. Would we use nitro? Maybe an analgesic because she is having chest pain, yes. Look at her oxygenation status. But now we have to make a decision as to what's the most appropriate facility for her to go to. Closest hospital. Because we're not seeing anything on this EKG. Now, if I'm with this patient for 20 to 30 minutes and I keep repeating this 12 lead and I start to see changes, that may change what I do. You have to be able to adapt on the fly. If by the third EKG in I'm starting to see an injury pattern, I start to see deviations of the ST segment, guess what? I'm not going to the closest hospital anymore. I'm going to go to a cath center. That's why you play an important role with the patient. One snapshot is not enough. You might miss something. And then how about the third case? 67-year-old female, left-sided chest pain, 7 out of 10. Patient has been prescribed nitro, has taken their own, unrelieved. Very credible story, right? Vital signs listed for you, not bad. Risk factors, we already know the patient has diagnosed coronary artery disease, has a history of angina, also has hypertension, and the 12 lead with this patient is on page 13. You've actually seen this EKG once already today, if you remember it. What is it? Good, high lateral infarct. Look at leads 1 and AVL, both lateral views. If we look at V5 and V6, which are our other lateral views, those are depressed. Although we do have reciprocal change in your inferior lead. So there's enough information here that we've got a STEMI pattern in front of us. And we prep that patient for reperfusion therapy. Triage them to a cath center if that's in the mix of where we can go. We think about treatment. A standard approach to care, aspirin, nitro, morphine if it's appropriate. So again, to summarize the ACS segment here, pay attention to your victims or your patient's story. Make sure you're evaluating risk factors. That's going to help you target the right patient. Acquire the 12 lead. Put all of the pieces together. And it helps better define for you a treatment plan that's specific for your patient presentation. Questions on the acute coronary syndromes that I can answer for you?
You said if a female takes HRT, that it protects their heart?
It is somewhat cardioprotective. It's not the same as if they had the own estrogen release within their body. So
I
you
thought
still
the
see.
big thing now, a couple of years ago, is they found that actually can lead into heart problems.
It can. It can. I just know that their incident does go up following that surgery in some patients. So there is a concern that they will look at monitoring the levels for patients. That some patients fail to take their medications as they're supposed to, so that makes an issue too. Other questions? Yes?
The 54-year-old, the module, I thought there was elevation,
Which EKG are you looking at?
the 54-year-old that you would take over the module, 11.
This one? Okay, so where are you looking at?
2, 3, 4, even a little bit 1,
So B2, B3, B4, and
even a little bit B1.
B1.
I mean B1, sorry, B1.
B1. So the question is the elevation a box or more? And I realize these are blown up and distorted and you can't see the small boxes.
Okay.
But if I use the TP segment as a reference coming across, if the elevation is there, it's probably not quite a box.
Okay.
And I will tell you, when it comes to electrophysiology and infarct recognition and the deviations you see from one patient to the next, it will drive you nuts because not everybody has a classic picture-perfect EKG. And I learned that very early on in my career. One of my very first jobs I ever had as a paramedic was when medical college had just opened up their brand new facility on Arlington. I took a job as a paramedic working in a remote telemetry room. So that was my job, 12 hours a day. I used to sit in a room and watch 30 monitors. And it was my job to call the floor or the unit if I saw irregularities. Now, of course, they don't do it that way anymore, but I learned a lot there. And I learned something very early on because I was working the day shift, and there were 5 cardiologists conferring and talking about one patient. They were all looking at the same EKG, and I've got 5 different interpretations of that EKG from 5 different physicians. So when you think about collaboratively, it's not an exact science. every interpretation is slightly different, and it just goes back to the nuances from one EKG to the next. There are variables that sometimes you just can't describe. But there was nothing that stood out to me, plus the fact I'm still seeing a concave shape to the ST segment. The T wave still look asymmetrical. I'm not seeing any reciprocal change that would nail it, so there's many things that draw me away from that. Okay. Other questions?
Is the TP segment, is that at the end of the T and to the beginning of the P?
Correct, so it'll be right here.
All right.
So we use that as a reference because the heart should be electrically silent. All right, let me transition into module 5 here. And we're going to talk about the high acuity patient. And we're going to do this with a review of coronary artery anatomy. But we're going to keep this very basic and very finite to the discussion that we want to have, and it's going to help you in the field for identifying those complications that may arise with patients. So I'm going to start off with a discussion of coronary artery anatomy. So I want you guys to flip to this page in your book, which should be page 3. 3? Is it 2? This one. That's kind of a crude drawing of the front and the back side of the heart.
It's 3.
Is it 3? So I'm going to color code this up on the screen. This will give you an opportunity to draw in your handout if you like, or take notes. But I want to review with you the left coronary artery. And the reason we're going to do this is by knowing some basics about how the arteries feed, it can actually give you great information as to what you're seeing on the 12 lead and help better define for you how you're going to treat patients. So the left coronary artery, colored red here, originates out of the base of the aorta, and there is a short section called the stump, or the left main. Fairly large vessel. And then in most patients, there's a huge bifurcation that takes place. And the next section we're going to talk about is the LAD, left anterior descending. And as its name implies, it comes down the front side of the left ventricle, and the anterior wall of the left ventricle, it would stand to reason, gets its blood supply from the LAD, from all the finger-like projections that go out. So proximally, up in this area of the LAD, it feeds the septal wall of the heart. Distally, it feeds the anterior wall of the heart. Okay. So we got the left main, the LAD proximally septal wall, distally anterior. The other vessel that comes out, colored green here, is the left circumflex, or LCX. It wraps to the side, and to see the distal portion of it, we actually have to flip the heart on its back side. The left circumflex sits on the lateral wall of the left ventricle. So guess where the lateral wall gets its blood supply from? The left circumflex. Okay? So those are the major divisions that I want you to be familiar with. Left main, LAD, and left circumflex. Now obviously there are small vessels that come out, and they all have names. You guys don't have to remember those. Okay? So let's envision for a moment that we have a plaque rupture a thrombus that's forming and vasoconstriction of the distal LAD. It's right here. Without even looking at a 12-lead EKG, where would you expect to see changes when that 12-lead comes spitting out? In the anterior wall, V3 and V4. So you can predict with fairly high accuracy the 12-lead that you're going to see just based upon knowing where the blockage is. And the reverse is true. I see V3 and V4 elevated, I know there's probably a problem with the distal LAD. And you would be accurate probably 99.9% of the time. What if the blockage were right here? Where would I expect to see changes on my EKG now? V1, potentially all the way through V4, correct? Because now I'm affecting septal feed as well as anteriorly, downstream. What if the blockage were right here? I would see lateral changes, right? And what are my lateral leads? 1, AVL, V5, V6. Well, let's keep going. What if it's right here? The left main is now occluded.
So V1, V2, V3, V4, V5, V6.
We call that an extensive injury, correct? Septal involvement, anterior involvement, lateral involvement. Excellent.
If it goes up into the stump, is that what they call the widowmaker?
It is. And we'll talk about that in just a second. So look at the EKG on page 4. Diagnose that for me real quick. Anteroseptal. Do you all agree that that's an anteroseptal injury pattern? And we picked that up because we've got J-pointed ST segment elevation in V1, V2, V3, V4. You also have reciprocal change in your inferior leads. Everybody got that? So let's say, for my EMS people here, this is a patient that you had in the field. You pick up the fact that you have an anteroseptal injury, you call it into the hospital, you declare it a STEMI, you take your patient to a cath center, you offload them, hospital does what they're supposed to do, they rush them to the cath lab. Let's say you're back there a couple hours later, and you ask the nurse, hey, I'm checking up on that patient that you brought in. And the nurse says, yeah, that patient had a proximal occlusion of the LAD. She would not have had to have told you that because you already knew the answer to that, based upon the changes you saw. So you can predict, again, with high accuracy, which vessel is affected and where, just based upon the number of changes you see on the case. How about this one? Next page. Good, high lateral infarct, everybody see it? 1 in AVL. While 5 and 6 have not transitioned, definitely you've got reciprocal change of the infarct here. What vessel is affected? The left circumflex. Because that's where the lateral wall gets its blood supply from. And then how about the one on page 6? Good, extensive anterior wall injury. Everybody see it? Most of your precordial leads have transitioned. 1 in AVL. While reciprocation is not strong here, there's enough evidence here that that's an extensive anterior injury. Which vessel is the culprit? The left main. Left main occlusion. So I'm here to tell you that when you pick up an extensive anterior wall injury in the field, this is what you should be thinking about right here. That's the one that's classified as the widowmaker. There are some patients that will have a total occlusion of their left main. You could dump your whole drug box into them. You can defibrillate them 1,000 times. You will not get them back. They are dead. Although I am here to tell you also that what if they only have a partial occlusion of their left main and you're seeing changes on the EKG? If you work those patients aggressively and always anticipate what's going to happen next, some of those patients do have a good outcome. You're just not going to know which one's which. That's what makes it complicated. So when you pick up evidence in your anterior septal and lateral leads, be thinking about this. It's most often from a proximal LCA lesion or clot. And here are the complications that come with that. Because your bundle branches, and a very important part of conduction, are fed by your left coronary vessel, these patients are high propensity for, guess what? Sudden cardiac arrest. So the take-home message here is, if you're treating a patient and you pick up an extensive anterior wall injury, always anticipate what might happen next. And what should be looming in your head is, my patient's going to arrest on me. I know it's going to happen, so I need to prep for that. My defib pad should be on my patient's chest. Maybe I should think about getting all my supplies out next to my patient. That way, when it does happen, I'm ready. And if you're one that thinks that you're going to have some warning in advance, you're sorely mistaken. Because this is the patient that will have a nice sinus rhythm on the monitor, be awake talking to you. You blink your eyes, their eyes are in the back of their head, they're out, they're in VFib. It happens that fast. And more often that you are ready, if you're ready and you have pads on, all you have to do is charge up your device, discharge it, and you have a great potential for getting that patient back quicker. You gotta be ready. Here's another reason to have pads on your patient's chest. Because the bundle branch area is affected, blood supply-wise, that's where we get high-grade blocks, ones that require pacing. So if you have your pads on your patient's chest, you're all ready to go. Think about these things as you're assessing and treating patients. Questions about the left coronary vessel up to this point? All right. Do you remember me at the beginning of this talking about AVR? AVR really traditionally had not been used for infarct recognition. So the thought process on that has changed. So the EKG on page 8, I would like you to look at that for a moment. This is an actual patient from the field back in 2013 from the Lucas County system. And let me give you a little bit of background. 75-year-old woman complaining of shortness of breath. Nothing major. She was awake, talking, hey, I'm having a hard time breathing. Initially, paramedics thought that she was a respiratory case because she had some respiratory background. They acquired multiple 12 leads on her. Everyone that spit out looked exactly like this. So I ask of you, what do you guys see on the EKG? Is there anything that alarms you, I guess? T waves are flipped over. Anything else?
Huge changes.
I've got T waves that are upside down. I've got depressed ST segments that are flat. They don't have a nice concave shape to them. So as I look at this, it's a globally ischemic EKG. So if I had to drop my EKG in one of the three subsets, non-diagnostic, ischemic, or injury, it would go into the ischemic basket. So the paramedics in this case picked that up. They were calling into the hospital, noted the EKG changes. They did not declare this as a STEMI, but they knew that they had something to watch for here. On the way to the hospital, she got considerably worse, to the point where she couldn't speak broken sentences because she was gasping for air. Her color was poor. They wheeled her into the hospital. As they're transferring her over to the bed, she arrested. She ended up dying in the ER. So the question remained with this, was there something on here that would have told me that was going to happen? And there is. And this is the new teaching that's gone along with this. And it's the use of AVR for infarct recognition. So up until now, this was the initial teaching. Didn't really show you the left ventricle, we made sure it was upside down. It gave credibility to our EKG. Now it has become this. It is now the forgotten 12th lead in patients with ACS. And it's now being recognized in the physician world, and it's important for STEMI recognition. If you do not know this name, you can jot it down. I can't remember if I put it in your book or not. But Amal Mattu, M-A-T-T-U. For any of you bloggers out there who would like to read additional information, you can use any search engine, put in his name. He has great information out there. He does a video series. The videos are 10, 15 minutes in length for any topic that you would want to know as a paramedic in the field. And he talks about this. He talks about SVT. He talks about extensive anterior wall MIs. And it's at the level that it's very easy to understand. I have picked up a lot from his video series. So when you've got time and you want to learn more things, I would encourage you to draw from that. There's a lot of great information there. So it's very easy to be distracted by the ST segment depression and T-wave inversion. Too many times we're thinking about global ischemic EKG. Is it ischemia? Is this potentially an end-STEMI? Could it be reciprocal change? But if AVR is elevated in the midst of all that, here's what you should be thinking. Left main coronary artery occlusion, LAD occlusion, that's specific, or triple vessel disease. In other words, it's an equivalent to the widowmaker. And our approach to care is this. Quick recognition for optimal outcomes as they require immediate and aggressive therapy. So I guess what I'm telling you here is a globally ischemic EKG, symptomatic patient, and AVR elevated is a STEMI equivalent. STEMI to this tune right here. That's why that patient arrested. Yeah, Chen?
Going back to that patient, is the shortness of breath a typical sign of this particular infarction?
Not necessarily. I mean, it could be just a typical chest pain patient. Respiratory is not always involved.
Okay.
As I give you this information, here's what's the challenge. Many of your ED physicians don't buy into this. It's because they're not educated. I'm going to tell you right now, you are smarter than them. I deal with the hospitals all the time. I will tell you, and I'll just use the name Toledo Hospital. I do a lot of work at Toledo Hospital, work with the staff there a lot. A couple of years ago, we would have talked about AVR elevation, they would have thought we were nuts. Guess what? They just recently changed their guidelines to add this information because guess what? They found they were missing these patients. It is real. It's something to pay attention to. Now, AVR elevated by itself is not enough. You got to put all the pieces together. Globally ischemic EKG, symptomatic patient, AVR elevation, that's when I would be concerned. Questions on that? One more random EKG, look at page 10. Global ST segment depression. AVR is elevated, but if you look real close, there's another lead that stands out that seems odd. Look at AVL. AVL is also elevated. What does that mean? Right here. ST segment elevation on both AVR and AVL, very specific for left main coronary artery stenosis. You will notice here that it does not say up here acute MI suspected. This is where you are smarter than the device. You gotta know the parameters to look for. Globally ischemic EKG, symptomatic patient, AVR elevation, and if I see elevation directly below it in AVL, I'm concerned. I'm concerned for that patient. I'm thinking about what's going to happen next. And what might happen next is my patient's going to rest up. And I need to be ready for that. For some of you, this is new information. Let it sink in, gather more information about it. Go to Matus' website, he talks about AVR elevation. It gives you better background information on what to look for. I'm going to move over to the right side now. If we're done with the left, any questions at all? All right, let's talk about the right coronary artery. Same pictures we'll use, color-coded. The right coronary artery originates out of the base of the aorta just like the left, just on the other side. So proximally, it sits right on top of the right ventricle. So the right ventricle gets its blood supply from the proximal RCA. Distally, you have to flip the heart on its back side. It wraps around to the back, colored in blue here. And in 90% of the population, it comes to the posterior wall and takes a 90-degree turn down the backside of the left ventricle. And this is known as the PDA, posterior descending artery. Proximally, it feeds the right ventricle. Distally, it feeds a small portion of the posterior wall and the inferior wall of the left ventricle. Proximally feeds the right ventricle, distally feeds the posterior wall and the inferior wall of the left ventricle. So that's the division for the right coronary vessel. So let's do just like we did with the left side. I have a culprit vessel right there. I do a 12 lead on this patient. Where would I expect to see EKG changes? Two, 3, and AVF. Why? Because those are leads that look at the inferior wall of the left ventricle. The distal RCA feeds the inferior wall of the left ventricle. So when I see an inferior wall MI in the field, I'm thinking of distal RCA occlusion. Okay. Now let's make this a little bit worse. What if the blockage were right here? In the proximal RCA. I do a 12 lead on this patient, what am I going to see? I'm gonna see the same thing, aren't I? 2, 3, and AVF. Because your 12 lead is in reference to your left ventricle. Remember, I stated that right out of the gate this morning. But I think you all realize that if the blockage is here, guess what else is now impaired? The right ventricle. So we need to do something differently to figure out whether the right ventricle is infarcting or not. So we're going to put on right-sided chest leads. But before we get to that, look on page 12. Take a look at that EKG and tell me what you see. Good. Everybody see an inferior wall injury, correct? 2, 3 in AVF. I have reciprocal change in 1 in AVL in my precordial leads. So right now we're thinking about right coronary blockage, correct? The question is, just by looking at this EKG though, can I tell whether this is a proximal occlusion or a distal occlusion? You can't. So now we have to think about altering what we do to assess. Yes?
So what's the significance of knowing whether there's proximal?
I'm going to, you're ahead of me. So I'm going to get there. Because yes, that would be a great question. Why do I care if it's not going to change what I do? But I'm here to tell you that you are going to change what you do based on that information, right? So you could do a complete right-sided EKG in the field if you wanted to. Instead of putting all the patches on the left, you put the same anatomic position on the right side. Who wants to do that in the field? Takes long, right? Hospitals, even in the ED, I wish they did right-sided EKGs. Many of them don't. So to make things easier for you, what if we just put one patch on? And they found that lead V4 on the right side will give you most information about the right ventricle. So after you acquire your standard 12 lead, pick up your lead 4 wire, put a new patch on it, attach it in the same anatomic spot on the right side. Hit the 12 lead button again, and then evaluate that single lead. And you're looking for, just as we've done on the left, look for an injury pattern. Now it tells me that the right ventricle is infarcting also. So same anatomic spot, and I was always an overachiever in the field. I always moved all of these. I did V3 through 6 because I wanted more information. But V4 is really all you need. So take a look at the EKG on page 13. You all see an inferior wall injury there. Here it is right here, 2, 3 in AVF. Reciprocal change in L and 1. You'll notice in this EKG, V4R, V5R, V6R. Patches were placed on the right chest. So are these positive for right ventricular infarct? Yes. There's an injury pattern there. Now, this EKG was electronically produced for this presentation. When you do a 12 lead with the patches on the right side, it's not going to give you an R. I think you guys all know that, right? You could put a patch on a patient's head, and it's still going to come out V4. It won't tell you where the patch is at. So you would have to write that in yourself. But again, you've got the information, you know what you're looking for. Now I have an inferior wall injury that's complicated by right ventricular infarct. So we look at those right-sided chest leads. So in our protocol, as in many protocols, anytime we pick up evidence of an inferior wall MI, we're always checking the right-sided leads. And this is why, since you asked the question earlier. very basic, you all understand this. Normal blood flow through the heart. So I ask this question in every class I teach. I very rarely get the right answer. I believe someone in here knows it. With every contraction of the heart on an average adult person, when the heart squeezes like this, how much blood is moved? What's a normal stroke volume for a patient? Who can give me the number? Come on, I know somebody knows it. Take a guess. I heard 60 up here.